Antipsychotic medications are medications used to treat psychotic disorders. Psychotic disorders can exist in different conditions in mental health. First, we have functional psychotic illness like schizophrenia, schizoaffective disorder, bipolar disorder, severe depression with psychosis, drug-induced psychosis, organic psychosis, or psychosis of unknown origin. So those are the areas where you can find psychotic disorder and the need to use antipsychotic medications. Sometimes we use them as tranquilizers as well, as a secondary use, but not for primary use. So in situations where you have acute agitation, behavioral discontrol, sometimes antipsychotic has been used to manage those acute situations. May not be on its own, maybe in conjunction with other medications like benzodiazepines, but commonly you would have heard Lagactil that's been used to tranquilize people is an antipsychotic medication. There is zipropentisol Acufase that's been used, and even some other ones like olanzapine and all those ones are being used in managing acute agitation or acute mania. So they can be used like that. So in situations where there's no psychosis but just for agitation, sometimes they can also be used for their sedating effect. But by and large, the type of antipsychotic medications we have are divided into two major broad types. We have the first generation antipsychotic medications, which are the old type of medications. They call them typical medications, typical antipsychotic medications. And they have subclass as well. I may not be able to give you exact details of those subclasses, but let's try and focus on the first generation for now that we commonly use in a formulary in this trust. They can exist in tablet form and also in parenteral form, like in depot. So the types that we commonly have in that formulary here are the alloperidol. It belongs to a class of butyrophenones. You need to check that as well, because there are other drugs in that family. But the commonest one that we use, like the one we gave to that patient, the one we saw in his home yesterday, is alloperidol, decanoate, 100 milligram. That's a depot. It's also available in tablet forms, which we can give. You know about chlorpromazine, which is Lagactil. We don't often use it here anymore, but you still find some old patients who have been as a legacy prescribed, chlorpromazine, and they take them in low doses between, let's say, 50 to 100 milligram, maximum 200 milligram orally. Okay. So the other type is the Depixol, or otherwise known as flupentazole. That flupentazole is available in tablet form and is also available in depot form. Okay, there's a patient we're going to see on Thursday, who I prescribe a test dose of flupentazole for depot. The oral form, I don't think you saw this patient with me today. She came in the morning. The one that I did a note for, I don't think you were there. She was prescribed the flupentazole oral, and she developed severe extrapyramidal side effects. So I had to discontinue that. She was discharged from the ward with that medication. When I saw her at home, she was suffering. So I had to stop that and put her on a different medication. But commonly, flupentazole tablets are in low doses, between 0.5, 1 milligram, maximum. You hardly see somebody taking as much as 6 milligram. But they can be quite effective for those people who can tolerate it. That is a tablet form. Then we have the Clopixol. Okay, Clopixol also can be available in tablet form. Usually it starts with about 10 milligram, so you can have it up to 10 milligram twice a day, once a day, 3 times a day. You can hardly find people taking up to 4 times a day. And if you check the BNF, they will tell you the range, of prescription for adult and for elderly. There's variation in the dosing for elderly and for adult. When we talk about the elderly, I can talk a bit more about that. So clopixol is also available in depot form. It's also known as zoclopentizole, as opposed to the flupentizole. So now the depot form is called zoclopentizole acetate, whereas the Accuphase one, the one we use for rapid tranquilization in acute distress and agitation, is called decanoate. Yeah? So it's called Accuphase. They call it Accuphase, clopixol Accuphase. So that one is not a depot. It's for immediate action to take care of an extremely agitated, quite disruptive patient. So we say Accuphase. Commonly, you see it used in an inpatient environment. But the depot one, we use it a lot in the community and also in inpatient. So you see a lot of our patients who are discharged from the ward into the community on zoclopentizole weekly, 2 weekly, 3 weekly, every 4 weeks. Okay? And the dose range between 100 milligram to 600 milligram per week. Before we move away from flupentizole and clopixol, particularly the depot, the protocol of administering a depot is that you have to first of all give them a test dose. And that's for patients who are particularly neuroleptic naive, who have not been exposed to neuroleptic medications. Antipsychotic medications are also called neuroleptics. So if they've not had that, so you're not sure about their tolerability of those medications. So in order to ascertain that, you give them a small test dose. Like flupentizole, we usually administer 20 milligram test dose. If they tolerate it without developing acute dystonia or any other severe side effects, then we can give them the treatment dose a week later, like 40 milligram. Then we can gradually titrate the dose up to 60, 80, up to some patient takes 400 milligram of that. Although that's very rare, but obviously you can also vary their dosing by spacing out the duration. Either you want to make it weekly or make it 2 weekly, or every 3 weeks or every 4 weeks, depending. So, but commonly it's administered on a weekly basis for patients as an intramuscular injection. For clopixol, we give a test dose of 100 milligram. So when you're prescribing, you have to say test dose first, 100 milligram. After a week, you now give a treatment dose of 200. You can then titrate the dose up, 300, 400, up to 600 on a weekly basis. As I said, some of them you may have to space the duration out to every 10 days, that's clinical judgment. Every 2 weeks, every 3 weeks, or every 4 weeks for patients. Now, there are some other first generation that we also use, but they're not very common, like fluphenazine, or called Modicate. It's commonly used in patients who have chronic, mental disorder, who have been diagnosed a very long time. They probably have been given a long time, and they've tolerated it, and it's helped them in managing their mental illness and relapses. So there's no point changing, the treatment plan. We just keep them on it. They've not developed side effects. It's maintaining their wellness, so we just let them carry on. They have not developed any concern about it. So, but it's not very common. So majority of the patients have stopped it, and we've had to use a different type of depot. But you will still come across some patients who will say they're on Modicate. Now, the dose variation for Modicate is, between 25 milligram to 50 milligram, up to 100 milligram. I think it's often a monthly prescription. I have to check that. I don't often prescribe it, so I don't know. But I think it's a monthly one. The alloperidol, as we said, is also available in depot, and usually is a monthly depot. Before we move on, alloperidol is used in tranquilization on the ward as well. It's part of the trust protocol for managing acute agitation at the beginning of admission. So when you're writing up medication, you put alloperidol dose 5 milligram, maximum dose 30 milligram, just to manage agitation before the doctor will review them. And then lorazepam, and probably sometimes we had promethazine. So we use alloperidol at low dose for that purpose. But if we want to use it for chronic mental illness, the dose is different from 5 milligram. We use up to 10 milligram. Sometimes that's oral, up to 20 milligram or 10 milligram twice a day, commonly. Then there is pipotil. Pipotil is also one of the first generation antipsychotic medications. I don't have much experience of prescribing pipotil, but I have seen patients who have been prescribed from CMHT who have relapsed, and they've come to us, and I've seen that they're on pipotil, and it's commonly on depot. It's a depot form. So yeah, the dosing of it, you have to check that, because it's not something I prescribe on a regular basis, but I know of it, and you need to know of it as well. So I think those are generally the first generation antipsychotic medication that we have in our formula. There are some other ones. There's a patient that came recently, about 4 weeks ago, who was put on perfluridol. Perfluridol is not quite common, but for some reason, a young boy, he was put on it, but he's developed some side effects from that, and his mom and himself said he wanted it stopped. I think it's a monthly sort of prescription. I think it was on 20 milligram initially. It was increased to 30 to manage his symptoms, but he asked for a change. And as I said to you earlier today, that sometimes we need to listen to the patient. We need to give the opportunity of choosing their treatment. And his request was reasonable, because even though he was on perfluridol, he still experienced relapse. So obviously that treatment has failed. So we needed to now renegotiate consent for different types of depot for him, which is now on. So in a nutshell, that's what the first generation antipsychotic medication is. We still use them, but we're not commonly using them. And they're not the first choice of treatment in treating mental illness in these days and age. And the reason is because of the propensity for patients developing extrapyramidal side effects. What are extrapyramidal side effects? Extrapyramidal side effects are this effect of first generation antipsychotics on other receptor sites in the brain, whereby they cause either excessive restlessness, tremors, rigidity, Parkinsonian symptoms, acute dystonia, and all those kind of things. I've seen a patient on the ward before that we gave alloperidol, and suddenly she just became like, I was taking her, and we had to quickly stop it. Just one dose, and within 30 minutes, she became very dystonic. So they have spasm of their neck, and it's quite an uncomfortable position to be in. So they sort of hatch their backs in a very funny position. There's one I remember, we gave sucralfate, very lovely, beautiful lady. And the next thing, she was like this. She just bent over. She was walking around like that. I had to stop the medication. My God, this is serious. We didn't know she was going to develop that. We gave a test dose, and that's what she did. She came up with. So we had to migrate her to something else. So some patients can have very, very frantic and quite florid reaction to those medications, and you have to reverse it. What do we do to reverse it, or even to manage? If you have to prescribe it, you need to think about antidotes. And the common anticholinergic medications that we use for them are...
Sorry, Dr. Ola,
yes.
I've handed over,
Teach it. Before you mention patient. Right, so So it can be quite flurry. So you have to be careful. So you may be called, maybe you're working on the ward and you've given them instruction, give haloperidol, and then the patient is so you need to be able to quickly reverse it. In reversing those kind of acute dystonia, you have to give muscle relaxant. You give lorazepam, either IM or whatever, to reverse it, and then give them procyclin in anticholinergic to stop it, the worsening of it. And the commonest anticholinergic medications that we prescribe is procyclidine. So 5 milligram procyclidine up to 3 times a day, or up to 10 times, 10 milligrams, TDS can be given. Like that lady, I think the one that I saw today, I initially increased her promethazine to 10 milligrams TDS, but she continued to experience serious problems. In fact, she developed, as part of her extrapyramidal side effects, akathisia. Akathisia is, persistent restlessness. She was just like this in a house. You couldn't sit still. Say, look at what you made me. And she looked like a zombie. And that's why a lot of people have this negative perception about mental health medications, or even coming to see us for treatment. That you're going to zombify me. You're going to make me look like a zombie. And what makes them look like a zombie is the effect, the Parkinsonian effect of the extrapyramidal side effects of medication that we're giving them. They have this very rigid mask-like face, inability to have changes in their affect. They can't smile. They have one mask look all the time. Their hands are stiff, and they assume a very very funny position, and they walk. They don't have hand leg coordination when they're walking. So what you see in Parkinson's disease, you understand what I mean? And they have tremors, intention tremors. Sometimes it could be just tremor, just like that, as opposed to what you see in Parkinson's, which is intention tremor as in Parkinson's. But this one is tremor at rest all the time. So, and agitation, and as I said, cogwheel rigidity and all this kind of thing. So those are all. So you need to read about extrapyramidal side, but you cannot miss it if a patient develops extrapyramidal, because you will see the patient's personality changed, completely. And for that reason, many of them may say, I don't want to stop this thing. I don't like to look like a zombie. And you have to listen to them.
I think in Nigeria, I've had a patient that had the acute dystonic reaction from, I think, chlorpromazine.
Chlorpromazine. It's very common with chlorpromazine. And because in Nigeria, we give high doses of this medication. We give high doses of Lagatil. People don't worry about the side effect burden and the effect on their functionality. You understand? People say, oh, he's mad. They give them every dose. They don't care. They just want to kill the madness out of them without considering the effect on their lifestyle, effect on their functions and quality of life. So people don't worry about that. So they overtreat them. And again, because it's a cheap medication as well compared to the rest of it. So people will first of all use them. They're very effective, but while they're giving you that remission, they're giving you other problems. But the other problem is what they don't treat very well in Nigeria. They just let them live. And for most people, parents, they're happy with it, because so long the madness or the symptoms are not there and they're just quiet in their own place, they're happy. But you can see a qualitative change in somebody's personality when they have, those kind of, medications being used for their treatment. So for that reason, science have evolved over time, and luckily we've managed to develop new generation or second generation antipsychotic medications, which are distinctly different from the first generation in terms of their side effect burden. But they're not different in terms of effectiveness, okay? In terms of symptoms, effect on symptom severity or improvement, they are equally effective. But obviously, the distinction is the side effect burden. And the second generation medications are mainly the ones that you hear about: the olanzapine, the quetiapine, right? The risperidone, okay? The aripiprazole, well, sulpiride and amisulpiride. it's sitting in the fence. Sometimes when people classify amisulpride as first generation, sometimes it's put in the category of second generation, and sulpiride as well. I haven't prescribed it in a long time. I used to do that when I worked in CMHT. And oftentimes you think about sulpiride and amisulpride when those ones like quetiapine, risperidone, they failed. You understand? And you're trying to sort of find other ways of helping the patients. Or maybe you want to use them in combination with olanzapine, for example. You had amisulpride in treatment-resistant cases. So, because one of the conditions or protocols according to NICE guideline is, at least for treatment-resistant, is to try a combination of two different antipsychotic medications. If you've tried it for up to 6 to 8 weeks and it still doesn't achieve symptoms improvement or improvement in symptoms burden, then you will now consider clozapine. Okay, clozapine is in a different class of it, though. I don't think we're recording anymore. I don't think I have even brain. I don't think I have space to record. Oh, it looks like it's still recording. Anyway, so I don't. So clozapine is in a different class of its own. I'm not going to talk about clozapine in detail now because there's a lot of protocol around prescribing clozapine and indication for clozapine. So it's going to be a different lesson, but it's still part of the second generation, antipsychotic medication commonly used for treatment resistance in this country. There are other new ones that have come to the market now, but I don't think they're part of our own formulary in this trust. In other trusts, they use them. There's a lot of marketers who are trying to push them forward, like capirazine, lurasidone. So you will hear them, but I don't think it's available for us to prescribe to our patients. But they're also equally effective antipsychotic medications. It's just that they're new in the market and they're not quite popular with most clinicians. So unlike the olanzapine, the quetiapine, the risperidone, and that. Now, let's now break it down. The olanzapine is now available in depot form, I think. I've not prescribed it in recent time, but it wasn't available like that before. But other ways in which olanzapine is used is the tablet form and the Velotab, the oral dispersible one. When you have a patient who's complaining of inability to swallow, or you are querying their compliance, or whether they swallow and they sequestrate the medication and spit it out, and you want to support their compliance, you prescribe the Velotab for them. And that's the one that's oral dispersible. Disperse under the tongue, they don't have to swallow it, so it gets dissolved and it gets absorbed into the system from there. So also the risperidone is available in a dispersible form. It's called risperidone quicklet. Okay, so that also is available in that form, and it's also now available. Before that time, we have Risperidone Consta. Risperidone Consta is the long-acting form of risperidone. I think for some, reasons, we don't use Risperidone Consta anymore. I think it's the way it's constituted. It tends to cause some, blister or pain when they give the injection. It doesn't get absorbed quite quickly. I think it's the way it's constituted. But in the early days of my career, we used to use Risperidone Consta as an alternative for patients who don't want to take the tablets. But now they've improved on it. Now we have paliperidone, which is now the long-acting form of risperidone. Okay, and whereas Risperidone Consta was designed to be given every 2 weeks, the paliperidone is designed to be given every 4 weeks. So, which is a better form of antipsychotic depot that we can give to patients. Although the name doesn't sound like risperidone, but it's still the same class of medication, paliperidone depot. Also, aripiprazole is also available in dispersible form now, which is good, and also available in depot form, in 300 milligram to 400 milligram formulation, and it's a monthly depot, which is good for most of the patients. The other thing is the way we use paliperidone. You need to understand, if you have to prescribe it, you won't prescribe paliperidone on your own. It has to be consultant prescribing anyway, but it's good for knowledge sake. because the protocol for prescribing this second generation depot is that the patient at least you would have commenced them on the oral form first. So you discuss with the patient and get their consent to say, this is the medication you're prescribing for them. They need to have the oral form. The injection will be given at so time, a regular interval. And once they agree, you put them on the tablet first to prime them, usually for 2 weeks. So after 2 weeks, you can now administer the depot. Okay? For paliperidone, we first of all give a bolus dose of 150 milligram. Okay? After 2 weeks on risperidone tablets. And then, of course, a week later, you give 100 milligram bolus dose. Now, after giving the second dose of 100 milligram, you still allow them to take the tablet for another 2 weeks after. So, because it's depot. Depot is not immediate action. It's a depot. It takes time to get into the circulation. So that's why you cover the patient for additional 2 weeks. So you make sure you engage with the patient and make them realize they still, even though they've had a depot, they'll still need to continue the tablet for a couple of weeks. Otherwise, they can relapse in the intervening period. And you don't want that to happen. And once the depot is established, then you give them every 4 weeks, thereafter, which means safeguard them. The good thing about paliperidone is also that it's not available as a 3-monthly injection as well. It's called Trevicta. So whereby patient will only have 4 treatments in a year, which is good. It's quite expensive, but I think I've seen few patients who are on Trevicta and they're maintaining well in the community. That's one of the development of science and in drug administration in psychiatry. Haloperidol is still a monthly one, as far as we know. Now, olanzapine has also been used for rapid tranquilization on the ward. So also aripiprazole injection, 9.75. So, I said to you that commonly we use things like Clopidogrel, Actifase, but nowadays sometimes if you're concerned about side effects, EPSC or acute dystonia and all those kind of things, you can prescribe aripiprazole for patients, 9.75, to tranquilize them, and of course they monitor, their physical health and all these things. And olanzapine also can be given, particularly in mania. You can ask them to give olanzapine injection for the patient in the community, in hospital. We don't give those kind of tranquilization in the community. If a patient in the community under opioid is so disturbed and so disorganized that we need to do a mental health assessment and find a way to get them to hospital. So all this tranquilization I'm talking about is not a community treatment, it's inpatient treatment. But you may come across that at some point because you may be on call. So those are the antipsychotic medications that we have. Now, what are the issues with these medications? Now, the protocol and NICE guidelines suggest that we need to ensure that any patient who's put on antipsychotic medication have regular physical health monitoring. Now, not only do they cause extrapyramidal side effects, there are some metabolic problems that could arise from the use of this medication. And a lot of our patients with mental illness, because of the functional disability, many of them are not physically active, their lifestyle is changed and all this, their diet and all this. So there's tendency for them to put on weight. And some of these second generation particularly, tend to increase patients' appetite, particularly olanzapine. Olanzapine and quetiapine is known for that. They're very notorious for that. So you find a patient who comments on olanzapine reporting that, they're eating a lot these days, and then they put on weight. And the weight is very noticeable, suddenly their clothes sizes become too big. They can't fit in their regular clothes anymore. Their face is fuller. Some of them will report, my abdomen. Commonly, the weight is accumulated around abdomen. So one of the things you measure is abdominal gait if you really want to monitor it. So one of the things you need to advise when you're prescribing antipsychotic medication is physical health monitoring. And what does that mean? What we're saying is that we need to, check people's height. So physical monitoring in antipsychotic prescription. So you're looking at the BMI, so the height, the weight, the blood pressure, the abdominal gait and circumference. Okay, so you can have that as a baseline at the beginning of treatment. That's what you should do normally. And of course, part of it is doing blood test, baseline blood test. What are you looking at? You're looking at the lipid function, lipid profile, looking at the blood glucose level, you're having baseline of the liver function test, thyroid function test. Sometimes we have to do prolactin level for patients. Particularly, I'll talk about that when we're talking about risperidone.
About ECG too.
Yeah, an ECG, of course, an ECG. So we do an ECG as well for them. So that ticks the box of physical health monitoring. And that monitoring has to happen every 3 months to 6 months, to ensure that there's oversight on them. Now, why is that important? It's important because olanzapine, and not only olanzapine, most of the second generation antipsychotic medications are known to cause metabolic disorders or metabolic syndrome. And metabolic syndrome is abnormal lipid and glucose metabolism, whereby people begin to develop increased cholesterol level, and that increases their cardiovascular risk and risk of death, in some of these patients. So that's why you do the ECG for them. So if they suddenly develop, somebody who is not diabetic and prescribe olanzapine suddenly become pre-diabetic, that olanzapine is not suitable. And if they have a strong family history of diabetes, or they're already on a diabetic patient, you will not want to prescribe olanzapine for them. So that would inform your prescribing choices for them. Because in terms of hierarchy, if you check that book, the Moscow guideline, they give you the different, grading, in terms of metabolic risk. I think clozapine is number 1, olanzapine probably follow, quetiapine follow that. So they graded them, plus, 2 pluses, 1 plus.
I'm not sure it's in this old one.
Okay, maybe it will be in the new one. You need to find the new one. So they graded it. So you have to memorize it, because then it helps you to prescribe for the patient. And when patients are complaining of some of these side effects or problems, you can address it. So you know which one to change to. The one that is, the safest is aripiprazole.
I say
Yeah.
it's almost for every side effect. The one that one can use for substitute.
Aripiprazole, it's weight neutral. This is how you sell it to the patient. So actually, if you're worried about weight gain, aripiprazole is a partial agonist and partial antagonist. So the propensity to cause extrapyramidal side effects is less, because the affinity for dopamine receptor is less, and they can easily be displaced. So the side effects burden is less. They don't cause weight problem. Now, one of the things with most antipsychotic medication and why extrapyramidal side effects occur is because of the diffuse effect of other receptors. Muscarinic receptors, antihistamine receptors, and several other receptors in the brain. So those receptors, for example, if the histamine receptor is affected because of the diffuse effect of that medication, it can make them eat more. You understand? It can make them, eat. Muscarinic effector can cause sedation and all that. So that's why. Whereas aripiprazole has less affinity for those other. It's not as diffuse like other medications. So it's very focused and very specific on the dopamine receptors. So therefore, it doesn't cause much side effects, and it's weight neutral. So people don't always complain of weight gain. It's non-sedating. That's why it's mainly antipsychotic that is prescribed in the daytime. Patient can take it in the morning. You understand? Because they can still take it in the morning and go to work and drive, because it's not going to make them feel drowsy. It's not going to make them feel tired. So it has that benefit in terms of, profile compared to the rest of the other medication. Olanzapine is notorious for sedation. Having said that, Sometimes we do have patients who we use olanzapine in the morning. We have to prescribe it twice a day for them. Sometimes, for placebo reasons, because the patient, you don't want them to be dependent on benzos and everything, and they're still agitated or very, well in the morning. You can just split the dose, or they say, the effect of the big dose at night is too much for them. So you want to split it. So you keep them 10 milligram in the morning, or 5 milligram in the morning, 15 at night, or 10 milligram in the morning, 10 at night, kind of. So you can vary. But commonly, olanzapine is a nighttime medication, and it's designed to work 24 hours. So it's not very common that you see it split, as a split. It's not designed to work like that. However, quetiapine is commonly a medication that is prescribed twice a day, and you have to do slow titration of quetiapine. You cannot, because of postural drop in blood pressure. So when you are initiating patient on quetiapine, you need to do it carefully. You need to advise them that you're going to slowly titrate the dose every 2 days or so. You increase the dose. You start with 25 milligram, then 25 milligram BD. Then you can begin to sort of adjust the dose. Either you begin to increase the night dose more because of the sedative effect, and keep the morning dose stable. Particularly if they feel tired, if they complain of tiredness and sedation in the morning, you keep the morning dose less stable at the same dose, and then you begin to up the nighttime dose. But total dose, obviously, you have to let them know. Like if it's total daily dose is 100 milligram, you can put 75 at night, 25 in the morning. If you want to up the dose, you can say, okay, give the nighttime come 100 milligram, 25 in the morning. So there's a lot of flexibility with the dosing, but with quetiapine, the range of dosing also is wide, as opposed to olanzapine. The range of dosing is between 25 milligram to 800 milligrams. Some patients are 800 milligram of quetiapine. There are not very many patients who are that high, but you will find some of them that they're still walking around. A lot of them in prison, they're on high doses and they're still able to keep awake, and you'll be surprised they will still be asking for more. So, but there is a wide range with quetiapine, but the key thing is that it has to be titrated initially and gradually increase the dose because of the effect of the postural drop. And it's a very, very sedating medication as well. So sometimes we don't use it just for antipsychotic at low doses. We can use it just to placate the patients or to keep them calm, to achieve relaxation, or take an edge of distress from patients. You find a lot of patients with EUPD, on quetiapine, and you wonder why are they on just 25, 50 milligram? Not because they are psychotic, but we're using it for that effect on calming effect on the tranquilization or the relaxation. And sometimes it's just the sense that, they're treating me with something. So placebo-wise, it works for some of them, in that regard. And quetiapine is very notorious for that. Now, it's also available in a modified release form. The modified release form is a once-a-day dose, okay? So you see quetiapine XL or Seroquel XL or MR, modified release, or XL means extended release, okay? So it's not going to see quetiapine, prescribed as a single day, particularly with a patient that is concerned about, daytime sedation. Okay, so you can say, don't worry. If you don't want to take the morning dose, we give you the slow release one, the modifier. You just take it at night. It works 24 hours. So that saves you from taking medication in the morning. Just take it at night. It will still do the same thing for you. So it helps. So is the way you communicate the effect and the use of those medications to some patients. You have to sell it to them. Because many times a patient, when you are prescribing, the first thing, what's the side effect? That's all they want to know. They believe every medication have side effects, and they want to be concerned about it. So it's the way you communicate that information and knowledge, and give them information leaflet as well. Say, you can go and look at it. If you don't want to start the prescription today, read about it. Come back to me next time. But if you think that delaying treatment will be worse for them, it's not in their best interest, you try and read the information to them there and then, reassure them, and say, let's start the initial treatment. If you do develop any problem, going forward, just let me know. We can always change the dose, or we can always change the medication. We can transfer it to something else. But this is what I think will be best for you, based on the history and the patient. So you have to look at, the lifestyle, the physical health history. For example, if they are diabetes, you don't want to do that. If they have, high blood pressure, you may think about whether should you prescribe therapy or should you prescribe something else. So you have to put a lot of information together to be able to decide which one will be most suitable. But in terms of efficacy, they're all equally efficacious. And that's what you tell the patient. No one is better than the other. But the only difference is those small characteristics, that makes them differ, and for convenience of the patient as well. So those are all the information we put together to make a prescription, the judgment for patients. Risperidone. Risperidone is a generally good medication. I always like prescribing it. It also has wide dosing variability and flexibility also. It starts from 0.5 up to 16 milligram daily dose for patients. The only thing with risperidone is, obviously, it is quite connected with development of hyperprolactinemia. So a patient's prolactin level just begin to shoot up after a few weeks of treatment. And hyperprolactinemia can cause a number of problems for male and for female patients. Fertility problem, galacturia, erectile dysfunction, sexual dysfunction. And you have to be able to distinguish between central hyperprolactinemia and drug-induced hyperprolactinemia. Okay? Now, the commonest way to judge that is, first of all, if you have a baseline blood test, prolactin level, and after placing the patient on medication 4 weeks later, even without symptoms, without complaining of symptoms, if you check the blood test again and the prolactin has suddenly tripled or doubled, it definitely must be linked to the drug that you've given to them. So if you discontinue that medication, likely that the prolactin level will fall back to normal over a period of time. So, but sometimes a patient may be hyperprolactinemic, but not symptomatic. Not all patients will complain of milky nipple discharge to you. Not all patients will be bold to say, I have erectile dysfunction, or I'm struggling with, amenorrhea or infertility. Some of them may not be able to say that. But for the ones who say it, you need to respond quite well to that and make sure that you try to address it. That means the treatment may not be a suitable treatment for them. So you need to find a way to deal with it. Now, there will be rare cases where the patient will say, this is the only medication that has worked for me. They've tried me on every other one. Other people say they don't work for me. Could say, every other one doesn't work. This one is the one. If you change it, I'm going to relapse. And yet they have 4,000 level of prolactin. How do you deal with that? I've seen a case like that before for a patient, a young girl. Prolactin level was raging high. And we've tried sucralfate, the girl kept relapsing. And the only thing that stabilized this woman's mental health was risperidone. But the downside was that we were having this raging hyperprolactinemia. So I had to, consult the endocrinologist to say, what should we do in this case? I think in that lady, we needed to put in bromocriptine or something to sort of, like a chelating agent, to sort of chelate the prolactin and sort of bring it down. First of all, we needed to rule out that it wasn't a central problem. And central in the sense that we're looking at pituitary gland. Because when patients have pituitary adenoma, okay, it's possible that they're firing, prolactin. And therefore, that's why. And commonly, they will have symptoms. I'll give you an example of a woman that she came to my clinic. She's been seeing other doctors, but they never took cognizance of her symptom. What she said to me was that, I'm not seeing very well. I'm having my vision. So I examined and I'm having headache and visual problem. And then it's no rocket science. I look at the medication. You're not on any medication that could be causing. I checked the prolactin. I did the blood test. I was looking for thyroid function was high. Prolactin level was high. This one was central. You understand? Something is happening there with vision. So the location of the pituitary sitting on that fossa. So it turned out that she had cancer, pituitary adenoma. So I had to refer her for MRI, and obviously she eventually had surgery. What if she didn't come to me? What if I didn't know? She's been seeing other doctors. But that complaint just rang bell with me. And then I just ran some tests for her. And I saw that this is the problem, really. And then she, luckily, she was saved because, pituitary adenoma could be quite metastatic. So obviously, we caught it at the right time. I was sitting there and compressing her optic nerves, causing visual problems, and of course, giving her headache. And we had to, help her with that. So we need to listen to our patients and be able to find a way to help them, as best as we can. So the commonest side effects of risperidone is hyperprolactinemia, and of course the effect of that on their reproductive health and individual personal health. Apart from that, it's not as sedating as the rest of them that we mentioned before. The effect on metabolic syndrome is not as bad as you will find with with olanzapine and quetiapine. Aripiprazole, we've talked about that, is weight neutral. People don't commonly complain about aripiprazole side effects. I don't think I've heard people may say at the beginning of treatment they feel a little bit agitated and all, but it's often self-limiting. Nobody has, I don't think I've ever heard anyone say, they have weight gain or something from, unless they're taking other things that they're not telling us. But aripiprazole is quite good. But the only thing I have with aripiprazole, I don't believe, even though they say they're of equal efficacy, but in my experience, I don't think it's as effective on antipsychotic or acute phase treatment of psychotic relapse or manifestation. I don't think it's as potent as olanzapine. Maybe it takes, and I'm not surprised because it's a partial agonist and antagonist, whereas olanzapine is 100% agonist. 100% antagonist, I meant to say. So, you understand? So, maybe that's why the effect of olanzapine is almost immediate. When a patient is quite unwell and manic, and you give them 10 milligram Velutab, you see the effect on them within 24 hours. Whether aripiprazole doesn't, in my experience, give that effect. So I wouldn't prescribe that as a first line for a manic or hypomanic patient. A patient who is not sleeping, who's elated, my first choice would be olanzapine, unless there are contraindications like physical health contraindications. Okay, that's when I will not prescribe olanzapine for them. So, but it's always my first choice. Maybe in my training, when we were training, olanzapine was quite popular. They push it to us a lot. And to be honest, my experience with olanzapine is far more than the other ones. But to be honest, they're all equally efficacious in a way. But I just don't put aripiprazole in the same category, like the olanzapine and quetiapine, for in terms of immediate acute phase management of mania or psychotic symptoms. So I don't. But again, everybody's practice is different. The other ones, I don't have much experience in prescribing them. The capirazine and the lurasidone, I don't have much. I don't even know the dose of them. If I need to prescribe, I have to check. If a patient is asking me, I'll say, hold on. I will check the information and the guideline and prescribe for the patient. So that's that. I'm thinking if there are other things that we've missed out from general monitoring. The important thing, you cannot talk about antipsychotic treatment without physical health monitoring. It's part of the performance management, in this trust and all over the country actually. Physical health, monitoring of patient is audited, from time to time. So you need to make sure that you have the ECG and the rest of it, for patients. We'll talk more about that when we talk about clozapine, because the clozapine is in a class of its own, and the way it affects cardiovascular function and cardiovascular risk is different, and the way it's used and titrated is different. So we'll leave that for another day. So I think in a nutshell, that's what we have. So when we put on EPMA, those are the kind of medication you will see that you can prescribe to patients. And of course, variation of dosing is something you have to learn by skills, by experience. You can't memorize everything, but the general principle is that start slow and and gradually titrate the dose. If you have to use high dose, consult the consultant and discuss it before you use it. And of course, if there's any sudden development of side effects, listen to the patient, respond to them, and sort of try to find a way to always reassure them that initial days of treatment you may experience some upset because it's new to your system. But if you can, unless it's an acute dystonia, which is an acute emergency, or maybe anaphylactic reaction. Do you get my point? There are very rare cases where you have anaphylaxis for some reason. So those kind of acute urgency, you have to stop it immediately. But otherwise, you can say persevere. See how it goes. If it continues to get worse, then we have good reason to change the medication. And if you think that the alternative would not be as effective, and there is EPAC, you give them procyclidine. So you will see a lot of patients who are still on those medications, but they're on procyclidine to support them. It's simply because alternative treatment will not be effective. So we made a clinical decision to stick them with this medication and just manage to improve their side effect burden by using procyclidine. Procyclidine is not the only anticholinergic that we use. Although the other ones are not commonly used, I don't think I've prescribed other ones before. I can't remember. I may have maybe one or two. Okay, like ofenadrine is another one, or benzo whatever. It's another one. I don't think I've benzotropine or something like that. I don't think I have experience of prescribed, but procyclidine is the commonest one. And the thing with procyclidine is that I don't think it's available in IM form. It's always oral. I wish it's available in IM form, And I think if it's IM form, because it's not quick acting, so it's not like when the patient develops acute dystonia, for example, or facial dyskinesia and all this kind of thing, when you give them IM, procyclidine is going to resolve the problem immediately. No, it's not. So you have to use benzos at that point. And then, of course, still give them procyclidine, which is longer to maintain. And that's how we manage those kind of acute emergency and resolve the issue. Right. So I think let's stop there for today. And we would continue with clozapine next time. And then read about it more. If you read and you have questions, come back, we discuss it. Observe my practice and prescription. You can ask questions as well. Why did you do this, doctor? Why do you change this? Why shouldn't you use this? Then I can tell you the clinical judgment behind the decisions I'm making. As I said to you, some antipsychotics at low doses, we use them for placebo effect. Even in the elderly, you find people prescribing risperidone 0.5 because, it's been known to help to manage old age agitation in dementia cases. You don't want to overload them with other things because they're not able to process it. So as you begin to prescribe them, your experience improves and your confidence in prescribing them improves. But for every patient that you think has psychotic illness, recommend antipsychotic medication. Arrange for baseline physical health for them. If you can do that before you prescribe, it's good practice to do it. But if you think that delaying treatment, is going to make their condition worse, you can initiate the treatment and then still, set up the physical health approach monitoring going forward. Okay? So don't say, go and read the treatment, I'll do blood tests and come back next week. In which case, patient would have ended up in hospital. You won't see the patient again. So you may have to start the treatment immediately, even though they've never been exposed to antipsychotic before. They may be neuroleptic naive, but you're trying to address the immediate distress at that point in time. And then, of course, you have the future focus in terms of, if I'm going to prescribe this medication, I need to have a baseline. If a patient is able to consent for blood tests on the same day, do it. Okay? Not all patients will be in a position to consent for you. So it may be that you have to, first of all, bring them to a state of wellness, by treating them. When they now stabilize and they're able to develop insight, you can explain to them, oh, that medication that kept you well, but that you're taking, we need to do some blood tests to have monitoring. And it's helpful so that we know your physical health is not getting damaged by the medication we're prescribing you. So, but that's the sort of the dynamics that occur in clinical practice when you see the patient. So we'll finish for today. Yep.
All right, sir. Thank you so much. Put it on the system.
Mm-hmm.
The people that are meant to do the test, do they know the full?
Yeah, because when you fill out that form, we'll print it out. So that printout form goes with the blood test we've taken. So they don't know because there are different tests that can be done. You have to specify which one you want. Yes, because not only would you put it on your own progress note on Rio to say this is because sometimes they check, this is the test you want to do, LFT, TSF, FBC and all those. You list U and E and all those things. You also on the form, and it's also recorded on Rio. So if anybody wants to check your prescription, they'll see what you prescribed. They will know that you're the one that prescribed it or recommended it, and they can see what test you've asked for. So yeah. So if you are not around, if you fill the form, the nurse can take the blood. They'll put the form in the blood, wrap it up, and send it to the lab. The lab would look at what tests they need to do, and then they will do it and upload on the system. So it's what you ask them to do that they will do. They're not going to be saying, why don't you do this? You be the one that make that judgment. Because, for example, if you want to do lithium level, and you have already done TSF and U's and E's, you have to just click lithium level. Just take the sample and send for lithium. They'll just do lithium. Okay? If you want to know whether a patient is low in vitamin B12 or calcium level or whatever, you just click on what you need to do. And that's exactly what they will do for you. So it's your own, because it's you that need the result to be able to help your patient. You understand? You're the one that know what you're looking for and what you are trying to establish. Like that man that we saw today, the one with the nose in the ring, ring in his nose. I ticked HbA1c because of his history of not managing his glucose very well. So I want to be able to use that to tell him that, look at it, this blood test suggesting that you have a history of poor management of glucose. So you need to go to your GP and get yourself, examined and reviewed. Do you understand? So I think that I don't have to do that. But because of his history of diabetes, I felt that's a good information. I just don't need the blood glucose level. It doesn't tell me anything. It depends on, because the random blood test we're probably taking. So random blood glucose here, you can tell me it's high or it's low, but it may just be it's just eating. So, but the HBC will tell me about its compliance and then its monitoring. And then I can use that information to advise him to say, your blood glucose, it's not good. It's not been maintained well in the last 2 months. You need to go to the doctor. And then this is the evidence of that. The same thing, if somebody is alcoholic, drinking alcohol, and you want to do an assessment, you want to check their liver function. Liver function, if the liver function is deranged, you can tell them, look you're already causing damage to your liver. Look at the, ALT and PL. Your liver enzymes are all over the place. Sometimes it shocks the patient to see that, hang on, this is damage I'm doing to myself. I said to them, it's only a matter of time. If you continue like this, you have a liver failure. You'll be needing liver transplant. You'll be on the transplant list. Do you want to continue to do this damage to yourself? And liver is central to body function. Medication that we're giving you, the liver needs to process it. So having that kind of psychoeducation with patients helps them. And you have to do GGT as well, to know how much, they're drinking and how much. GGT is significantly raised. So if you're telling me this is how much you are drinking and the GGT is raised, then you're lying. You're underreporting what you're drinking, and we have evidence of that. And if you continue to do that, you're doing yourself a disservice. So you can advise them on that to say, look, if you don't do something will go wrong, and there are complications to your welfare. So the request you made is based on what you want, and to be able to help your patient to determine their care, and help them to educate them on recovery process as well. I mean, like our colleague, I said, go and do your FBC. I said, oh, I've always had history of low iron. Okay, maybe that's why you're tired. Go and check it. So things like that. So yeah, okay.
Thank you very much.
All right. Take care. Bye.
Yes,